Hello, good evening, everyone, and welcome to this evening's session on iron deficiency and what is the effect, how common it is, what is the effect on the population. This is the commonest cause of anemia in the world, and it's extremely common, very, very common in our place. And also we are going to see the pathophysiology and the management, and also what is microcytosis, what is the relevance of this small red cells. So I am privileged to chair this session today. And we have just to remind everyone, if you have any question, please use the question and answer panel to submit your questions. In case of any difficulty, use the chat box. You can connect to the administration. They can help you. At the end of the presentation, please complete the evaluation forms, so that will help us to also learn from you and also to improve the sessions. And also you can claim your CME after that as well. So we'll go now to the first presentation, which will be an overview of iron deficiency in hematological disorders. This will be by Dr. Amar Lal. He is a senior hematologist at Toam Hospital, a very prolific speaker, and he is an excellent clinician as well. So Amar Lal, please welcome.
Thank you, Dr. Marashi, for a nice introduction and inviting me to speak on overview of iron deficiency anemia and hematological disorder. It's not moving. So it's going on. Sorry. So in next 20 minutes, I was just thinking what I tell you, nothing to tell you. You are all experts of anemia. However, anemia and supports are as old as hills. So I will take you some retainer by giving you some examples of the patient, then the reminder how the burden and the severity of the disease, then the refresher by going through the guideline, and finally finisher to take home message. So which guideline we use to treat hematology? We use 4 guideline, and NCCN, we top off it, we use it sometimes expert online. So NCCN guideline says anemia can be defined as hemoglobin less than 11. And how you test this? You test by peripheral film first, and then you check, as you mentioned here, that first check the retic count and MCV. So by this is a reminder, anemia means decrease in hemoglobin, and RBC, which diminish the oxygen carrying capacity, which cause the hypoxia, leading to signs and symptoms of anemia. Then it's classified, remember, three beers, some are too small, which is microcytic anemia, like iron deficiency anemia, thalassemia carrier, and some are too big, like folate B12 deficiency, macrocytic, and some are just right, which is aplastic and hemolytic anemia. So after this, we had to find what are then other causes. You have to take history, hemorrhage, and any nutritional problem or any hemolysis. So in a nutritional problem, which is the topic of our interest, so iron deficiency, in iron deficiency, what we found, low hemoglobin, low ferritin, and different saturation. So we'll see how to treat in all these scenarios. So anemia is defined as mild when hemoglobin is 10, moderate 8 to 10, and severe is less than 6.5. Anemia is the most common type of any iron deficiency anemia is the most common type. 90% you find is the iron deficiency anemia. And here you can see the burden of the disease. Almost half of the population has iron deficiency or micronutrient deficiency. Some are found pre-operative, some are found surgical intervention, and some are found incidental finding. The cause is actually either requirement was high but not given properly, like in pregnancy, lactation, menstruation, and increased loss like bleeding, or most important thing is poor diet, vegetarian and socioeconomic status, and finally decreased absorption like patient has gone for gastrectomy and GI disease. So iron deficiency anemia is the most common cause, as data from 188 countries was seen. 66% was found iron deficiency anemia and some other related causes in medicine. And if you go in surgery, interestingly, in surgery, they found like pre-operative overall 1/3 of patients they found anemia, and most common was found in the colorectal cancer and gynecological disease. Now, coming to the oncology, 40% patient anemic at enrollment of our oncology, and interestingly, 70% eventually become anemic after 6 months. And however, 40% we have seen they have received treatment for anemia. What is the cause of the cancer and anemia? First is the patient, maybe hemoglobinopathies or diminished nutritional status or disease problem like bone marrow infiltration and bleeding. And third is treatment related like radiotherapy and chemotherapy. So anemia in non-hematological malignancies like solid tumor, which is present in the 40% and most common found in the lung and gynecological malignancy. And more interestingly, hematological malignancy, it is found 80%, mostly is with the MDS, leukemia, and lymphoma is the cause. Now, in a routine cases, we can say this is 28-year female who was severe iron deficiency anemia. Severe by definition is you say is less than 6. Oral supplement was not worked. Eventually, it was given IV, just as maintaining with the supplement of IV, and she is going now normal. And similarly, one example is the moderate anemia who was given initially oral, then finally they switched to the IV iron. She is maintaining like normal hemoglobin. This is a routine case. The important thing, which is my topic, is hematological and oncology. This is beyond the conventional case. 60-year female, 2-month history of B symptom, finally found adenocarcinoma of the colon. Chemo was started. During chemotherapy was found hemoglobin 8.8, low MCV, other parameters was normal. Now the important thing here, please understand, there are different scenarios can come with the ferritin and saturation, and these scenarios can be low ferritin with a different saturation or high ferritin, 3 more scenarios with the different saturation. So these are the 5 different scenarios can come, then how to treat it. Again, going to the NCCN guideline, there is one absolute iron definition. Absolute iron deficiency by definition is ferritin is less than 30 and saturation is less than 20. What is the treatment? Treatment is the IV iron. If it works, fine. Otherwise, you consider it is functional iron deficiency. Now, what is functional iron deficiency anemia? Functional means here it was 30, but here you can say ferritin goes from 30 to 500, and saturation here you see in absolute is 20, but here you say 50%. So 30 to 50 and 50%, we call it the functional iron deficiency anemia. What you do, you will give only not IV iron, you will push by the EPO as well. I will show you shortly what is the mechanism of it. And the third is the possible functional iron deficiency when ferritin go up to 100, 800, but saturation is still less than 50. And here you also consider IV therapy. But when you are confident that this is not iron deficiency anemia, so when the ferritin is more than 800 and saturation is 50%, then story finished. There is no IV iron or oral iron needed because this is not iron deficiency anemia. So now I was talking functional iron deficiency, just bit focus on this. Normally what happen, any person who is anemia or hypoxemia, what happened, liver decrease the hepcidin level. When hepcidin level is decreased, it release the iron actually from enterocyte and macrophages. What happened? During inflammation like chronic kidney disease, hepcidin level is high, they don't release iron. And when they don't release the iron, it means iron is there, but it's not releasing iron to the bone marrow to make the RBC. This is called functional iron deficiency. To make it more clear, there is very good cartoon. Absolute iron deficiency means you see this empty iron stores, means like less than 30 ferritin you will found. But functional iron deficiency, you see there is huge iron up to 30, 500 to 800 ferritin you found, but saturation will be low. This is called functional iron deficiency. But when you push it by the giving EPO, it will release from iron stores to it comes to the bone marrow. So this is how it works. Now, coming back to 5 scenarios. First scenario, which I mentioned, ferritin less than 5, saturation is less than 4. So what is the appropriate treatment of this patient? Option 3 is appropriate. Why? Because ferritin is 30 and saturation is less than 20. This is called absolute iron deficiency anemia. This is typical case. And during chemotherapy, actually, we usually give IV iron, not oral iron. So we have option FDM and FCV, we will discuss later. Now, second scenario is ferritin is again low, but saturation is a bit high, is 22. Now, this is called discordant. Here, what you will do, option 3. Option 3 is IV supplement. Here, you first replace by the IV iron. If it's corrected, fine. If not corrected, later you will push by the EPO. Now, third option is, this is again, we see commonly in chronic kidney disease or our malignancies, ferritin is 580, but saturation is very low. And what is this option? And this option 2 plus 3. 2 plus 3 means EPO and iron supplement both. So first you have to give, in this stand, EPO should be considered first to push it, because as I mentioned, iron is store is good. So you have to release iron. And if it's decreased ferritin, then you give IV supplement as well. So now scenario number 4, you have ferritin only 100, but saturation is 30. So now what is the option? Option 2 is here. You have to push by the EPO to release the iron. Now, fifth scenario is ferritin is 500, saturation is 40. Here is also option 2. You have to push by the EPO to release the iron. So now you see it's very important to understand, when should be given, when should we not be given, what is the function and what is the absolute. Now, what should be given? What is the difference between oral and IV iron? Oral iron is always efficacious. It is common misconception, because oral iron with food and drugs may reduce absorption, and 70% people feel GI side effect. And most important thing is, more you give iron, hepacid is upregulated. I show you here shortly. In this figure, you see as days increase, the level of hepcidin increase. When hepcidin is increase, it means the availability of the iron is decreased. So more you give oral, it interrupts the normal level of the hepcidin as well. Now, what is the other option? IV iron. IV iron is emerging effective effect. It can be used when intolerance or contraindication to oral iron, severe anemia, and short time to major surgery you can use, and you can use in all chronic disease as well. Now, IV iron, again, there are so many advantage, but there are disadvantage. There is dollar and toxicity as well. So you have to keep in mind, and there are traditional forms and there are new generation form of IV iron. Now, which we should choose? This is an important thing. As all the iron I mentioned here, IV iron, there are 6 IV iron. They have different size and weight, and they have different pH. So they work is differently. The important thing is, please make sure their utility, dose, clinical studies, toxicity, you have to sure. So far, the literature says 3 iron are very active, FTM, FCM, and Venofer. These are 3 very active iron. I go shortly, as somebody has told, without data, you are just another person with an opinion. So it's important to show, to suggest which data is favoring to which medication. I will go shortly for next 5 minutes. So this is for one data clinical trial, which is about 1,500 patients. What they did in this, they use FDM, which we call IAM, iron isomaltoside, or this is actually 1 or 2 doses can be given, and then iron sucrose, which is conventional iron, up to 10 doses. So Venofer and versus this iron isomaltose, you have seen both they reach the good level of the hemoglobin, but the ferritin level is high, which was seen IM, and saturation was high. Also faster and greater early response was shown in this study. So another study is PROVIDE study, again, isomaltoside, which is monofer, versus again Venofer. Again, they have shown the all patients, they have higher hemoglobin level in all patients, and especially gynecological malignant patients as well. Then there is third data, which is very important to compare. There is, everybody know hypophosphatemia is the big issue in IV iron. Now, in this randomized trial. Here, this is Monofer, and this is FCM. I call this FDM and FCM. There are two. So FDM is just one dose every 9 months to 1 year. They prefer to give 1000 milligram. And here are two doses of FCM. This is also we use to give two doses, 6 monthly or one doses every 1 week. So it means two doses versus one dose. Then we see what happened. You see the efficacy is almost, there is no difference. They are doing great, both. But the problem is the hypophosphatemia is higher in FCM as compared to the FDM. And now again, there is another PROCEED study. They have shown if just one shot is really continue, keep hemoglobin level up to 365 days. Yes, it's mentioned, it keep the continued level as normal. And other study, there is NEMO study, which they've shown some patients, they really need more than 1000 milligram, especially those patients who have GI problem, who they lose a lot. It means they need more iron as compared to the general population. And they have shown the higher is better in these patients. Now, do you think all this I am favoring to FDM? It's not like this. There is data for FCM as well. There is also 31 published data, and there is certain post-marketing data as well. And the short history is like they have very long this data they found, which is the best one, which is second, third, and fourth one. In this study, they found FCM is the best one, and then IS iron sucrose, and third one is IMM, and fourth one is oral supplement. So they have shown, all three are better if you use it. There is difference of efficacy as per their protocols as well. Now the results have shown also in their sponsored the FCM better. I showed before in the others study the FDM better. So it's very difficult to say. In some studies they show FDM, some say FCM. So somehow the both are good. And the thing is there is difference of hypophosphatemia and hypersensitivity. So this you have to keep in mind. Now, what I have done last 20 minutes, I have gone through, as you have seen, overview of iron deficiency anemia and hematological disorder. First, I tried my best to testing retainer and reminder how to test. And second thing is I tried to go through the refresher through the NCCN guideline, when should be treated with the EPO and iron supplementation. And the most important thing is, which we call the finisher take home. And what is this? How you predict. Now, this is the question I keep for my other speaker who may focus it. This is my closing question to them. Which iron is the best in the bunch evidence-based FDM, FCM, IS, oral? So now we have, these are all the options. I would say most important thing is first this green one, that please consult nutrition consult. This is very important because it's not only iron you may find in normal people, they have other micronutrient deficiency as well. Just correcting iron is not sufficient, so they should consult nutrition consult and oral supplementation if they can take it. If they cannot, then they come all three options. Venofor versus FCM and FDM. If it's not available, then the final is the iron dextron and iron ferrigluconate. So with this, I charge you a retainer, I charge you retainer, and finally I finish it. Thank you very much, Dr. Marashi. Yes.